Assalamu alaikum. Let's dive into IUGR, intrauterine growth retardation. It is a very important topic of the obstetrics and taken from the USMLE inner circle. Start with a video. Can you tell me the name of the diagnosis? Look at the hand of this young lady. Can you see the deformity? If you put it in the comment box. IUGR, intrauterine growth retardation, fetal growth restriction. Definition is weight less than 10th percentile, weight less than 10 percentile for gestational age, weight less than 10 percentile for gestational age. Risk factor is maternal hypertension, pre-gestational DM, genetic abnormalities, and congenital infection. Hypertension, maternal hypertension, pre-gestational DM, pre-gestational DM, genetic abnormalities, and congenital infection. Appearance is large anterofontanel, thin umbilical cord, large anterofontanel, thin umbilical cord, loose peeling skin, and minimal subcutaneous fat. Evaluation: how can we evaluate placental histopathology and consider karyotype, urine toxicology, and serology? And in case of neonatal complication, polycythemia, hypoglycemia, hypocalcemia, and poor thermoregulation. Neonatal complication is polycythemia, hypoglycemia, hypocalcemia, and poor thermoregulation. This is fetal growth restriction. In fetal growth restriction, you have to see, is it symmetric or is it asymmetric? How? What is the definition? Ultrasound estimated fetal weight less than 10th percentile. Ultrasound estimated fetal weight less than 10 percentile for gestational age. Onset: if it onset in the first trimester, then the etiology is chromosomal abnormalities and congenital infection. If it happens on second or third trimester, it may be uteroplacental insufficiency or may be due to maternal malnutrition. Clinical feature is global growth lag in case of symmetric, and in asymmetric, head sparing growth lag. Head sparing growth lag. So asymmetric is absence head. That means head sparing growth lag. How to manage: weekly biophysical profile, serial umbilical artery Doppler sonography, and serial growth ultrasound On these way we can find out fetal growth restriction. How can we monitor and treat complications like hypoglycemia, hypothermia, and polycythemia? For hypoglycemia, frequent screening and frequent feeding. For hypothermia, skin to skin with mother and examinations in incubator. And for polycythemia and hypocalcemia, seen if patients develop poor feeding, vomiting, and jitteriness. Fetal growth restriction can be a complication of a maternal vascular disease, type 1 diabetes mellitus, chronic hypertension, which can cause chronic placental vasoconstriction and ischemia with resultant uteroplacental insufficiency. Patients with fetal growth restriction have a high risk of this: intrauterine fetal demise, and it require an immediate umbilical artery Doppler ultrasound. It require an immediate umbilical artery Doppler ultrasound to assess placental perfusion. Bicornuate uterus with two separate endometrial cavity, has less room for appropriate egg implantation, placental development, fetal growth. Patients with these abnormalities, patient with these abnormalities are also patient with these abnormalities are also increased risk for preterm delivery, fetal growth restriction, and malpresentation. Preterm delivery, fetal growth restriction, and malpresentation. Fetal constitutional smallness is associated with short maternal stature, low pre-pregnancy weight, and fetal female sex. Constitutional smallness presents with an ultrasound estimated fetal growth less than 10 percentile for gestational age, normal umbilical artery Doppler evolution, and appropriate interval growth. Constitutionally small infants have long-term outcomes. So for IUG or for fetal growth restriction, these box that symmetry growth weight, fetal weight less than 10 percentile for the gestational age. You have to remember the fetal weight less than 10 percentile for the gestational age, and you have to look at the trimester according to the causology, like if it is congenital infection or if it is chromosomal abnormality, should be the first trimester, and if it is others like uteroplacental insufficiency or maternal infection malnutrition, maybe second or third trimester, and you have to see the clinical feature also. Okay, if you look at this question, what have you found? I'll not gonna read the whole question. I'll try to show you the tactic of finding answers from this question. Look at the estimated fetal weight at fourth percentile. So according to our definition of fetal growth restriction, this estimated fetal weight is less than 10 percentile. So now we need to look for the cause. Okay, we have found another thing. This patient has ASD, atrial septal defect, white fixed splitting, atrial septal defect. So looks like it is happen in the first trimester because first trimester there is congenital, in first trimester there is organogenesis, so chromosomal abnormality and congenital thing happens in the first trimester, so it is fetal chromosomal abnormality. So this fetal growth restriction, and it is look at the ultrasound show fetal head circumference, abdominal circumference, estimated everything, fetal head circumference, abdominal circumference. It does not spare the head, so it is not head sparing, so it is not asymmetric, so it is not happening in the second or third trimester, so it is symmetric. Looks like fetal chromosomal abnormality or followed by first trimester congenital infection like toxoplasmosis, like cytomegalovirus. These are the thing, these are the congenital infection may cause these. And the atrial septal defect, this patient age more than 35 suggestive of chromosomal abnormality like trisomy 21, like maybe Downs. If we read this question, another question, estimated fetal weight is at 8%, less than 10%. So, and in here there is no chromosomal abnormality. His gestational age is 34 weeks. Look at here, he has hypertension. She's taking labetalol for hypertension, diagnosed 5 years ago. Still look at her BP. Here her BP is 142 over 82. So looks like this fetal growth restriction fetal growth restriction happened due to the uteroplacental insufficiency second and third trimester. Okay, if we look at the ultrasound shows head and femur measurement consistent with 32 weeks. So it is more like equal, but abdominal circumference consistent with 27 weeks. So head circumference, head sparing looks like closure, but abdominal circumference is very, very low, not consistent with her gestational age. So looks like it happened in the second and third trimester. Looks like it is asymmetric. So it is uteroplacental insufficiency. It is asymmetric fetal growth. Asymmetric fetal growth happened in the second and third trimester. And there is head sparing. Okay, if we look another question, look at this question, another question. Mm, look at examination. Infant's weight 2.3 kg, placing in the third percentile. Weight is third percentile, placing him at third percentile. Height is 18 inch, placing him on the fifth percentile, and head circumference 33, and placing him at 10th percentile. This paucity of the subcutaneous fat and around skin peeling looks like these 39 weeks of gestation are he has preeclampsia with severe feature. Max Sulf is used, and after Apgar score is 8 by 18, 1 minute and 5 minutes, and there is this. So weight is 2.3, third percentile. His weight, fetal weight is, if it is less than 10 percentile, looks like fetal growth restriction. Why it is happened? It happened due to polycythemia. So birth weight is less than 10 percentile for the gestational age. So most cases of fetal growth restriction is uteroplacental insufficiency, which is impaired blood flow to the fetus with subsequent decreased oxygen and nutrient delivery. Fetus adapt to hypoxic, nutrient depleted in utero environment by shutting blood from non-vital organ, liver, subcutaneous fat to preserve blood flow to vital organ, which can lead to this polycythemia, this hypoglycemia, this hypothermia. It can cause hypocalcemia and peritoneal asphyxia, mm, and meconium aspiration, perineal meconium aspiration. So these are the things can happen as a complication. So okay, last but not least, if we look at this IL topic, the last question of this fetal growth restriction, find out the a pelvic ultrasound show an intrauterine gestation normal. Mm, So this 29-year-old woman with initial prenatal care appointment, 12 weeks of gestation, nausea, vomiting, BMI looks like normal. On pelvic examination, there is enlarged uterus and mobile adnexia is non-palpable. A pelvic ultrasound show an intrauterine growth intrauterine shows an intrauterine gestation with normal cardiac activity. The uterus appears to have two distinct, look, there is two distinct endometrial cavities separated by a septum, as there is two endometrial cavity which is separated by a septum. So looks like fetal growth restriction because there is two cavities, so it is compressing. Poor vascularized uterine septum, small uterine cavity, and decreased placental perfusion, fetal growth restriction. And there is malpresentation So septate uterus is the most common congenital. Septate uterus is the most common congenital uterine anomaly and is often associated with poor obstetric outcomes like recurrent pregnancy loss, fetal. So congenital anomaly, common congenital anomaly can happen. Fetal growth restriction and malpresentation, preterm delivery due to abnormal uterine vascularization, decreased placental perfusion, and impaired uterine distension. So this is all about intrauterine growth retardation. Can you see? Do you want to see the video again? Look at this and tell me your diagnosis in the comment box. Okay, thank you.